Back to you, Committee Member Sellers.
Thank you. Is there a motion to move to resume open session at 9:59 a.m.?
Committee Member Gibler, so moved.
Is there a
Committee Member
second?
Virgin, second.
Thank you. All right, roll call vote. Committee Member Anderson.
Approve.
Committee Member Gibler.
Approve.
Committee Member Hammond.
Approve.
Committee Member Sellers approves. Committee Member Virgin.
Approve.
Committee Member Wickenhagen.
Approve.
All right, this motion passes. And we will begin with an update from Executive Director Runyon.
General.
Yeah, nice.
Good morning again, everyone. It's Executive Director Runyon. So this update really just centered around all of the upcoming membership opportunities we have on the committee. There are several openings coming up in 2026. And of course, we have certain requirements in statute. So pursuant to ORS 689, 649, parent 3, the term of each member of the committee is 2 years. A member whose term has expired shall continue to serve until its successor is appointed. And if a vacancy occurs, the person who is a representative of the same state agency as the departing member shall serve for the remainder of the term. So it's specifically, we have a few of those coming up in April 21st, 2026. For example, committee member Anderson's appointment will end, and that's not available for reappointment. April 30th, 2026, committee member Sellers' position is available for reappointment or appointment. Both of those are RPH positions, of course. 4/21/2026, there's an APRN position. Committee member Wickenhagen, that position is not available for reappointment, so we need an appointment there. And then the MD position at 5/31/2026, committee member Virgin's, that position is available for appointment. So currently also have one physician position available for appointment also. So for current members whose positions are available for reappointment and you're interested in applying, please reach out to staff member Melvin for more information on how to do that via Workday. We'll begin advertising the open positions in January. And if your position is not available for reappointment, please help spread the word to your colleagues. You can find more information on how to do that and supplement your efforts on the board's website underneath the opportunities webpage. Some of the positions are, exceedingly difficult compared to the pharmacy positions or even the APRNs to get filled. So we appreciate any help there. I'd also reached out to Nicole Krishnaswamy, the ED for the medical board, for a little help in augmenting our efforts to spread the word on that. I think several months back that she did send out a communication to all of her licensees about that open position. We haven't had any bites yet. So even before, next year, before those positions become available, you're welcomed and encouraged to go ahead and start helping us spread the word on those appointments there. And then the next item for business is the committee will need to vote today on proposed meetings for 2026. And staff has taken a considerable amount of time to arrange these in a way that makes sense related to the cadence of our board meetings and rulemaking hearings. So we have identified 3 potential dates on the docket here, which you'll see on the agenda. It's January 15th, 2026, March 5th, 2026, and then in the fall, September 3rd, 2026. And so back to committee member Sellers for committee discussion and vote on those dates.
Thank you so much. This is committee member Sellers. Everybody look at those dates, I'm guessing, and kind of thinking about your calendars for next year. So first off, is there a motion to move to convene virtual PFAC meetings on January 15th, 2026, March 5th, 2026, and September 3rd, 2026?
This is Committee Member Wickenhagen, so moved.
Is there a second?
Committee Member Gibler, a second.
All right, we will move on to our roll call vote. Committee Member Anderson,
Approved.
Committee Member Gibler,
Approve.
Committee Member Hammond,
Approve.
Committee Member Sellers approves, Committee Member Virgin,
Approve.
Committee Member Wickenhagen.
Approved.
All right, this motion passes. We will now be discussing mailing A, formulary devices and supplies, epinephrine, starting with Executive Director Runyon and subject matter experts Crystal Sharp and Rob Nutt. Take it away.
Executive Director Runyon, as you know, the committee reviewed epinephrine during the April 2025 PFAC meeting. However, after that review, there were some revisions that we'd like to review with the committee today that were identified by staff. So
This is A first. Oh, okay, sorry.
we'll go through the formulary part of it first, and then to review the protocols. At that point, I'll turn that over to Smees, Sharp, and Nutt. So there is a proposition to add this to the formulary or the list of devices and supplies that pharmacists can prescribe pursuant to the authority in ORS 689-645. As pointed out previously, there are a couple of additional elements, or well, actually not for the formulary, for protocol, the 115, 330, and 335 would be required there. So again, there's a proposition to just add epinephrine to the list of drugs and devices that pharmacists can prescribe via formulary.
I think we might want to just like have the conversation about the protocol at this,
And then come back.
and then
to
just act and come back to the, if that's okay with the chair.
This is Committee Member Sellers. Yes, that's okay. These two are so interlinked that I think it's important to discuss them together. So.
You do not speak.
Same discussion.
Just like walk through it like how you guys were gonna normally walk through it.
Subject matter expert Sharp and Nutt, are you on the call, and can you unmute? Just want to make sure we can hear you okay.
Testing
Hi, this
for
is
me.
Crystal. I'm on the call.
Thank you. Thanks, Rob. Okay, back to Executive Director Runyon.
Executive Director Runyon. So I think at this point, we'll have the SMEs review the protocols, right? I understand that correctly, as far as the intent. Yeah. And then
And allow
after,
things, yeah.
yeah, then after that, we can open it up for discussion and discuss the utility of either or both.
Well, then, thank you very much, members of the board. Crystal, would you like me to start and then you can finish it off?
Sure, go ahead.
All right, here we'll go. Thank you for the opportunity to present this, members of the board. Regarding epinephrine, the current rules that it's written under are pretty dated. They come from a time that you need a little paper copy, which I get it. A lot of prescriptions are still in paper copy. But it's almost like this little golden ticket that comes through OHA that has a certificate that the pharmacist has to receive, writes on the back of it. This is harkening back to a day and age of almost quill and ink in a sense. And times have changed. The practice of pharmacy is still very much the same as far as our intended purpose, which is taking care of our patients and helping them be safe and educating them on that. And I think epinephrine, and Crystal and I have talked upon this ad nauseum regarding how epinephrine could be made more available to the public regarding a life-saving medication or a device here that in many ways is similar to, let's say, the opioid epidemic that has plagued the nation. And Narcan has been entrusted to pharmacists to be able to treat opioid overdose and a treatment that is indeed life-saving, where epinephrine treats anaphylaxis. Most commonly, many of us think of food allergies and bee stings. The pharmacist is in a unique position to be able to educate a patient that has interest and should be able to receive these medications readily without having to sign up and go to these long lines of, because healthcare access where pharmacists are immediately accessible. And they could make an appointment to see the pharmacist, or they could see the pharmacist for that, be trained on how to use it, go through some of the information that Crystal has provided and put forward here, and be able to be prescribed and written and leave the pharmacy with a medication that could possibly save their life. They may never use it, and we hope that they don't. But the opportunity for them to have that and have that access, I think, is incredibly important. And I think that pharmacy needs to step up to the point of coming into a different age. That's everything that I wanted to kind of say to start it out. Crystal, did you want to add anything to this?
I don't have anything additional to what you just said, but I can start off with the first document and kind of work our way through the few documents that we have to share today. So thank you again for having us. As previously mentioned, we were here in April and had a pretty in-depth conversation about anaphylaxis, and after board review, it was determined that there were some edits that needed to be made. So we have made those edits in conjunction with the board and are back to present our new protocol. So first we have our essentially header page or front page of our protocol. Essentially this just outlines the different documents within our protocol and states that there are no limitations existing for quantity of epinephrine devices or refills for this protocol, and there are no specific pharmacist trainings required to partake in this.
And then Crystal, this is staff member Melvin. Just let me know when you're ready to go to the next.
Oh, okay. Maybe go to the next one, please.
Does the committee and committee member Sellers, if you want to ask if there's questions before we proceed to the next, that would be helpful as well, because I can't see your hands.
Yes, of course. Sorry, this committee member Sellers. Does anybody have any questions before we move on?
Yeah, this is committee member Gibler. Just to put this in our pocket, no training is required according to this draft protocol. And if a pharmacist is to prescribe epinephrine off the formulary, the ORS or OAR says pharmacists must document appropriate training for anything prescribed off the formulary. So I just want to, it's a question maybe we can discuss after we're done. Like if that's a big deal, if that's going to cause confusion, or what we think about that, or if I'm wrong. Maybe I'm wrong.
I'm looking at the path.
Okay. Good question, committee member Gibler. We will come back to that. How about that? I'll leave this open and we'll go to the next one. We'll come back. Board council can look up some information for us. Okay, Smee Sharp, back to you.
All right, thank you. So next we have the self-screening patient intake form. So this is the form that the patient would fill out for the pharmacist to assess if they're eligible to receive epinephrine. So I'm not going to read line by line because I know we've seen this a few times, but we have pertinent patient information at the top. So name, address, contact information, provider information, known allergies. And then we get into a few additional questions. So they will be required to answer if they've been prescribed epinephrine in the past 24 months. If they have been prescribed, there is space for them to notate who their provider was, contact information, and when they had last received their refill. And then they will also be inputting their weight to help the pharmacist dictate what product is appropriate. And then at the bottom, we have a space just for additional questions or concerns that they might have during their visit. And then they can sign the form. And then essentially there's a spot for the pharmacist to assess to see if they are appropriate to receive epinephrine. So the one dictating factor here would be if they had not received or been prescribed epinephrine in the last 24 months, then they would be referred to their provider. Any questions on this document?
This is committee member, I'm sorry, staff member Melvin. Committee member Wickenhagen pointed out that the no checkbox was missing, so I added that yesterday. Just that's why that's highlighted yellow, Crystal.
Perfect.
Thank you for that addition.
And
Oh, I'm
this committee
sorry.
member Sellers, committee member Wickenhagen has their hand up.
Yep, I was just gonna make the same comment that Rachel did. Thank you very much.
Thank you.
We're ready for the next one, Crystal. Pathway.
Yes, thank you. Yep.
Go.
All right, so this is a very condensed pathway compared to the last time we were here. So just based off of the information that the patient provided. So step one, have you been prescribed epinephrine within the last 24 months? So yes, then you could proceed to step two. If no, then they would be referred to their provider. And then as we make way to step two, what is your current weight? So they would put that there. If the patient weighs less than 15 kilograms or less than 33 pounds, then they would be referred to their provider. Any questions on the treatment pathway?
Committee member Gibler.
Hi, this is committee member Gibler. Thank you. Number one, asterisk optional, and then there's information listed below. Is that information that's listed below what's optional?
I don't think there is anything for the asterisks. I think it's just there.
So we need to
I
strike.
think it's just a copy and paste issue, yeah.
Oh, okay. Sorry. There we go. I think that's just an error.
So what's optional? That's the information below is optional?
Like the prescriber information would be optional.
Yeah, is the
that what
phone
you're
number, all that, is that optional? What's optional?
I personally don't think that should be required for the treatment pathway per se. When the pharmacist is assessing, they may not have all of that information readily available. But if they do have some of that information where they can confirm the patient has received the epinephrine within the last 24 months, they can provide that on this document.
Sorry, go ahead.
Oh, I just think maybe we can just remove that information. Just it's yes or no. I'm not sure if having this optional information available will just like cause a lot of time trying to research the exact date it was last filled.
This is committee member Sellers, and I agree. Because if we were not using that information, why are we collecting it? Because I guess that would be my question: is do you expect the pharmacist to validate and verify that it has been filled in the last 24 or prescribed in the last 24 months?
I am open and for removing it if the committee approves that.
I think they validate that it was prescribed in the last 24 months by checking yes.
Okay, so do we have consensus to strike that, Courtney?
Would you like me to go through a roll call?
I think, does anybody disagree with it?
Yeah.
I think you're good.
Okay, do we need to amend the prior document then as well? Where we're asking the patient, this one here? Or
And
leave it?
this one doesn't say optional, so this
Yeah.
one indicates as mandatory. So is it mandatory or not? It would, I don't see exactly how this information can be obtained in a lot of cases. The exact date, if they're coming from, if they're not, if they don't have a history at the pharmacy or if they've moved from out of state, the patient will know, like, well, I think it was in July of 2024 was the last time I filled it. Or they may have it with them, the actual epinephrine with them, which will have the date, but sometimes they won't. So I think this is a large barrier to have the exact date. The prescriber, unless they have their epinephrine with them, they may not have this information. Anyway, back to you.
Yeah.
This was an attempt to be thorough, which is great. But I think that the consensus here, and I don't want to speak for anyone on this, is to remove barriers to care. And anything that could possibly do that would be construed as something that we could strike. So let's put that forward as, let's remove that unless anybody says otherwise.
This is Committee Member Sellers. Does anybody on the committee have any objection to striking that information?
I think if the SMEs think that might be a good idea, that further validates my concern that this might be a barrier.
Yeah.
Looking at rules. Keep going.
Oh, okay, so we will look at the legal validity of that and come back to this. So SME Sharp, are you ready for the next document after this one?
Yes, thank you.
Okay, yep. So this would be four, right?
Yes.
Okay, here we go.
All right. So this is the required provider notification. So if the patient does have a healthcare provider, the pharmacist will inform them of what was prescribed at the visit. So if we can, there is just general information at the top for the healthcare provider where they're sending it to. And then as we move down below, these are the options that you will see on document 5, the sample prescription that can be used. But according to the patient's weight, there are various devices that are appropriate for them. So essentially, whatever device is selected, that would be indicated how many doses and refills that were prescribed. And again, there's no limitations on the quantity or refills for this protocol. If we could scroll down. There was one.
Oh, staff member Melvin, real quick, if you see the asterisk next to other, we put a strike through that because again, I think that was a formatting issue. We couldn't see what the asterisk was referring to. So you're going to see that I struck that throughout.
There was actually one other thing I was hoping we could remove. On the second portion, the 15 to 30 kilograms for Neffy, there was a symbol after the word refills. That was on a sample prescription, but should be removed from this document.
Thank you.
I think
Committee
the
Member
reason for that-
Gibbler. Oh,
Go ahead.
sorry, Committee Member Gibbler, you had your hand up.
Oh, thank you, Committee Member Gibbler. I just want to verify, and I assume this is so, but the patient is documenting their weight up at the beginning, and so that's the weight we use, and the pharmacist doesn't need to have a scale and weigh each patient, correct? Okay, thank you.
Correct.
So going back to the list thing, I think the reason obviously that was there was because then when you get to the next thing, if you wanted to notify the provider, that would be the only way you would necessarily know. And I believe what you guys have done in other protocols is that if known and kept it in as like if known and then listed out that way. Because otherwise you wouldn't get this information. So if you go back up to the
So this is the patient facing one.
right, the patient facing one. If you have that there, and you could just say yes if known, and then have all of that there, and then again put it on the next one if known, because that way you have it, and you can easily do the step of providing the notification to the, because what the rule says on the notification part. Let's see what it says. It says provide notification to the patient's identified primary care provider or other care providers when applicable within 5 business days following the prescribing of a formulary or protocol, compendium, drug, or device. So there's a rule that says you have to notify, and then and I believe the way you guys have handled that before is if known.
It's like our hyphen or just how?
I would say yes, and then go down, return, and then if known, please provide or something. I don't know how you guys have done it. I can look at other.
I know that there's space above in the patient information where they can list their healthcare provider and their phone number.
Okay. But I wouldn't think that I wouldn't necessarily say the healthcare provider that necessarily had provided them this.
Mm-hmm.
So I mean, that's, you guys can, but also the notification is just, can be by general. So you guys talk amongst yourselves.
We have 2 folks that have comments or questions. First is committee member Virgin, and the second is committee member Gibbler. So committee member Virgin, it's yours.
Committee member Virgin, that was my statement that the healthcare provider name I think is sufficient.
Okay.
From my perspective as a primary care provider, they might have seen an allergist, but as their primary, whoever the patient recognizes as providing their primary care, I think should be the one to get the notification to keep track of their constellation of medications. And that would be sufficient.
Committee member Gibbler.
Yeah, committee member Gibbler, if it has been prescribed in the past 24 months according to the patient, but they don't know this information, then where's the section to document that?
What to do next? Yeah, I mean, I think it's fine. Like, if you guys feel comfortable, as long as the healthcare provider name and that information up there is enough, then I think you're in compliance with the rule.
So strike it off.
So you can, yeah.
So do we want to revert back?
Yeah,
back to you, Courtney, to decide if you guys would like it to be stricken, I guess, how we originally had it.
Yes, committee members, does anybody have any objection to striking it and just using the healthcare provider name listed in the top section of the intake form? Okay.
Then do we need to revisit again?
No, I think you're good there.
Leave this one alone. Okay. Okay, Crystal, back to you on this one.
All right. Any questions or concerns about the provider notification?
I have none. Do any other committee members have any questions or concerns?
And going back to the question that member Gibbler raised in the beginning about the training. So what that document says, it says no additional training needed. And what the rule says on training, so if you go into 855-1150-330.
Just open it.
And then go to 5. That says, so this is for protocols. So when training is required for protocols, and A says ensure training and education requirements have been met prior to engaging in prescribing activities. And so for this one, right, then no training requirement would be needed because the protocol says it's not needed. And then if you go down to 6, so for each drug or device the pharmacist prescribes your formulary, the pharmacist must. And then it's A is ensure training and education requirements have been met prior to engaging in prescribing activities. And without anything saying that there was a training requirement, they wouldn't necessarily have a training requirement that route either.
So if they adopt 2 paths, training on one, not training on the other.
There wouldn't be any training for either one, I believe, because there's no training requirement delineated out for the formulary option.
I don't this committee member Gibler, I don't understand the reasoning behind that. Why would, if the OAR dictates if training is required under prescribing under a formulary, the protocol says no training required, which is fine. I agree with that. If we have both options available, it adds confusion. If we have just one or the other, it creates less confusion in terms of training requirements. To me it does.
So I'm just saying, like, the way that I would, like, if these were both in practice, like if both of them went through, I'm just saying, like, I don't believe either one of them requires a training based on the way they are written. Either process would require training.
This is Committee Member Anderson. I think what's maybe helpful is to kind of think about, like, in one of those areas, it talks about just making sure that the pharmacist feels comfortable, and if they don't, they would need to get training for that. I don't know that comfortable is necessarily the right word, but there is an area where it just says that they need to make sure that they're able to do it. And so if they do feel comfortable and able to do it, and I would say this is definitely one of those areas that they don't need to get training.
This is
I'm
committee
saying,
member
like,
Sellers. Oh, sorry. Yeah, no, I completely agree with committee member Anderson. I guess I am concerned that the way that this is written makes it seem like you have to have training and ongoing documentation that you is like, I like that in the protocol it's spelled out that no training is required. If I were going through this, I don't know what I would do with is it section 6A for the formulary? Yeah.
Formulary, yes, 6A.
Okay.
Yeah, that's my.
I mean, I would think the training is pharmacy school, but
yeah,
who knows?
Yeah. Well, that's what I was like. I'm not even sure what training that's referring to for the other things, but I'm trying to look to see if there's anything else in rule about training. Are you aware? Are you for, like, prescribing in general that you need training for?
Am I interpreting this wrong, committee members and committee member Anderson? It seems.
Yeah, this is Committee Member Anderson. I mean, I guess I'm thinking about the other devices that are currently on the formulary, and I don't think that anybody has felt like they need to go through training to prescribe for a spacer, or, you know what I mean? But maybe you might want to for continuous glucose monitors, for instance. Like, you may not be as comfortable with those particular devices, but those are on the formulary. It would just be something that I think most pharmacists understand, that it's something they don't need training for, but if they wanted it, they could get it.
I would say the sheer number of times I've instructed people how to use an EpiPen would be, I mean, and I know that's not the only aspect that we're talking about here, but what I'm getting at is and I forget which committee member said it, but I think they said it quite well, which was, I think the training is pharmacy school. And as long as the pharmacist feels competent regarding the medication on it, and the formal education that they've received, I think that meets the training requirements. That would be my opinion.
Executive Director Runyon, kind of in line with that intent, I'm looking in Division 115 pharmacist, 0120 responsibilities personnel. One of the requirements is to ensure initial and ongoing training is completed that is commensurate with the tasks that the pharmacist and persons under their supervision will perform prior to the performance of those tasks. So although it could be confusing potentially if evaluated in isolation, I think it does align with how we've addressed this, generally speaking, in other parts of our rules. So if that provides any clarity, in other words, it's similarly worded in the pharmacist division about any and all other tasks that the pharmacist may undertake or anyone under their supervision may take. So basically it's saying if there is training or education required or experience required, that you're meeting those requirements and documenting it.
And the rule for formulary and protocol are identical, right? A and A are identical. So meaning what my point is like saying is that the protocol itself is saying no additional training is required. It's not saying no training. It's saying no additional training to do this protocol is required, which would be the same, I guess, analysis you would take on the formulary as well, as you would be saying you don't need additional training for prescribing epinephrine. So it doesn't say no training is required, it says no additional training required. So it's not saying like if there are other training requirements in rule or statute that matter for other reasons, we're not saying you don't have to have those, you just have to have no additional training is required to prescribe this drug.
Executive Director, and I think that's another opportunity as well once the committee decides on what they want to recommend to the board, and then the board at its next meeting decides on what they want to adopt. It would be an additional opportunity for us to use all of our platforms in addition to those available platforms from state associations, for example, to communicate this in as broad a mechanism as possible, and to kind of circumvent or really to address this potential confusion before it arises. I know I talked about that on one of the last coalition meetings, is how do we use all of these platforms to extend or broaden our reach? Because we're still having, unfortunately, we're still having some communicative gaps, if you will, even with the COVID protocols or the respiratory vaccine protocols recently. For example, we put an email blast out to 30,000 plus licensees and registrants. We communicated to the associations and so on and so forth. We have a newsletter option as well, but we're still finding individuals that are seeming to miss those communications. So I think we're doing a little work internally trying to understand what options are available to broaden that reach and scope. But I think, coalescing with or augmenting the efforts that we're doing here, putting in here, we can combine that with, education and outreach best we can to help spread the word and minimize confusion and hopefully increase uptake as a derivative of that.
Excellent. Thank you so much for that clarification. And this is Committee Member Sellers, sorry. So, we had discussed previously sort of the pluses and minuses of having a protocol, having the prescribing happen via protocol versus via formulary. And I think that one of the big topics of discussion was a concern for confusion among pharmacists and kind of thinking of pharmacists as the end user of these decisions. And then, and then B, just kind of, the administrative burden and the steps that it takes. And is there one sort of pathway that is just lower in barriers, and should we recommend one, or should we recommend both? And so I think that was something that I just wanted to sort of let the SMEs know kind of where our previous sort of discussions had fallen was kind of, what is the best option here, because it sounds like, and I could be interpreting this incorrectly, that the formulary option is actually the lowest barrier between the two. Okay. So I wanted to open this up to other committee members to sort of discuss and kind of think through, now that we've had, first of all, oh my gosh, I'm sorry. Crystal, do you have anything else to still present, or have we presented all of the documents for the protocol? Oh, you're on mute.
Oh, the last document, which we have pulled up right now, is
Okay.
essentially almost identical to the one we just walked through. The only changes is that this is not the provider notification, so that stuff has been removed. And then there is the asterisk and the other symbol after NEFI, because that stuff should remain on this document. So
Okay.
the pharmacist is aware of the age limits for NEFI and that they are able to prescribe any FDA approved devices for anaphylaxis if something else comes to the market that is not listed.
That asterisk needs to stay next to NEFI.
Yes, I'm,
Okay. Oh,
I'm
fixing it.
removing the strikes. We were not sure. Okay, so footer stays is what she's saying. Yeah.
I think
And
just
committee
for
member Gibbler.
This is Committee Member Gibbler. Before there's any discussion on whether one option, formulary or protocol, is preferred or whether both are preferred, I'd just like to ask the SMEs if what their thoughts are on that, because there might be some details we might be overlooking, whether both options should be on the table or if one would be preferred over the other.
Yeah, I can start with that. So I do agree that the formulary route has the least amount of barriers, and I appreciate that there's, less administrative burden on the pharmacist. But I know there was also some discussion about pharmacists not being informed about the differences between the formulary and protocol. And I will say, just as a community pharmacist that engages with other community pharmacists, there is still a lot of education to be done on the formulary. I personally have not really seen many at all prescribe off the formulary. A few more off of the protocol compendium. So I'm a little hesitant to just put it on the formulary and not as a protocol, surprisingly. Those are just my thoughts as a working pharmacist.
And I'll add my 2 cents on it. First of all, I'll say here to everything Crystal just said. I mean, that's, I'd like to back what you said with one little caveat. I'm probably less concerned on that one. Everything she said has merit on that. I too have seen less pharmacists use the formulary. So that in itself is an educational barrier of a type, right? In fact, I'm embarrassed to say that I didn't even know that there was a formulary. I mean, I know that there's a formulary and have known for a while, but it was like one of my last things I kind of found in pharmacy, right? And I like to consider myself at least somewhat versed. And yet at the same time, that was one of the last little nuggets I actually kind of grabbed. So I'm sure there's plenty of pharmacists that are completely unaware of the ability to use that avenue to be able to give access. So yes, I agree with Crystal on that. And at the same time, the impetus and the onus is on the pharmacists to be able to know their practice well and capitalize on it and offer those abilities to our patients. So I agree. And at the same time, I say, and that needs to be put back onto the pharmacists, and the savvy pharmacists will know how to be able to put that out there to their patients. So yes, I agree. And I still think that it should be put on formulary, if nothing else. Thank you.
Committee Member Anderson.
Hi, this is Committee Member Anderson. Just a follow-up question to that, based on those responses, is for the SMEs, if we were to add it to the formulary and have it as a protocol, would that be confusing in and of itself for pharmacists if we had it in both spots?
You first, Crystal. You're more applicable than I am. I'm more institutional. You're more retail. So you first.
Yeah, I do agree that would be very confusing. Yes, that would cause, I think, even more confusion. If we did add it to the formulary, and not as a protocol, back to what Gary was saying, and that this could be like a spark to help educate the community on the use of the formulary and how we can utilize it and how easy it can be if you are aware of how to use it. So I think we could make that step potentially if the committee agrees and use that as a platform to really provide that education out to our licensees.
I was going to say something very similar. And in fact, I'm mirroring. It sounds like I'm aping everything that Crystal says. But what I'm getting here is I think what Gary had put forward as far as being able to speak to this at the conferences and so on and so forth that the board is at and respond. This is a golden opportunity. You've put out 30,000 emails, and I think the statement was you are always going to have these challenges communicating, and you're always going to have those challenges with those pharmacists who pay attention and actually read things the way that they should in the practice of their license, right? So you are always going to have those challenges, but allow the pharmacists to be able to have that tool to be able to treat their patients. And I think the formulary is the area that it should rest in, ideally. Thanks.
Thanks. Committee Member Gibler.
Yeah, thank you very much for those comments, both of you. And I appreciate that. And I think the protocol is very important. I think we need to move forward with the protocol, but based off of the points that were brought up, I think adding it to the formulary can be an opportunity for Gary and the board staff to educate on the formulary, and that pharmacists can use that formulary to develop their own prescribing practices, whatever those look like. And as long as they, adhere to the rules. Is the opportunity for growth, because as Crystal Smee Sharp said, we aren't seeing a lot of prescribing off the formulary, but adding epinephrine, which will also have a protocol that's separate if they so choose, just creates more, I think, awareness of the formulary in terms of education and what can be done that may not look exactly like the protocol, but will still be valid. And so that's a professional opportunity for pharmacists, and it could increase access to these formulary items.
Thank you. So I guess I want to be clear. So what I'm hearing you propose, Committee Member Gibler, is adding both at this time, and then using the formulary as a way of educating pharmacists on how to use the formulary.
Yeah, I mean the risk of confusion is I think the opportunity outweighs any risk for confusion. The opportunity for education, as long as the board staff, including Executive Director Runyon, is willing to educate on the formulary and what can be done with epinephrine on the formulary versus comparing and contrasting it to the protocol in those educational forums, could be very, very helpful to licensees in the state. Because it'll be the first time I think we have both a formulary item and a protocol, and that's an opportunity. It's going to create confusion, but it's also going to create opportunity for education.
This is Committee Member Anderson. Correct me if I'm wrong, but I think I heard the SMEs actually say the opposite, that once kind of considering the idea of having it in both places, that it would be preferable to only have it in one and only on the formulary was their recommendation. Is that correct? Or did I misunderstand that?
I think after all of the discussion that's been had and after committee member Gibbler's comments, I'm changing my mind, and I think that it would be more impactful to have it in both areas and have the board provide that education. Since we would have it in both spots, it would be easier to relay those differences to licensees in that manner. So I promote having it in both places.
And I very respectfully disagree. I think it should only be on the formulary, but I'm so excited to have this on there, and as an opportunity for pharmacists to be able to use, I'm amenable to either. I don't think it would be destructive to add it to both. How's that? Does that answer the question a little bit better? I lean towards towards formulary. I'm okay with both.
Mhm. This is committee member Sellers, and I too am leaning toward formulary only. And here's my thought is that if you have it on both, I mean, the pharmacists that are comfortable with using protocols only are really not going to learn how to prescribe under the formulary. So while it may provide some level of increased access, I think that the pharmacists that are, really up on it and paying attention and out there, being very proactive, those folks are going to do, what they can with when they get the education that they may need. And the folks that aren't are never going to, right? Like they're just not going to participate regardless of sort of which side we're on. So I guess my thought is, the formulary side makes sense to me.
This is committee member Anderson. I would agree with you, committee member Sellers. I like the idea of just keeping it with the formulary personally.
Committee member Virgin.
Committee member Virgin. I will preface my statement with, I am also leaning towards formulary only. My only question is, do we believe that having it there because it's not well understood could be a barrier to prescribing, and that there may be more comfort in having a protocol?
This is committee member Gibbler. That's my main concern initially, is that we're not going to improve immediate access by adding it to the formulary, because pharmacists aren't used to prescribing off the formulary. I like the idea of using epinephrine, putting an epinephrine on the formulary only in a more ideal, educated world. But that, I think the onus is on Executive Director Runyon and the staff to educate the licensees on this and what they can and can't do when prescribing off the formulary. And it's just going to take time. So I'm okay with just the formulary. I wouldn't vote against that, but I do think there's still, if access is an issue now, then we're delaying this opportunity now by not approving a protocol, which is fine. I think just we need to discuss it just a little bit more, I think. And I'd like to hear from others, especially committee member Anderson and Sellers, what your thoughts are on that, since you do recommend formulary only.
I do, this committee member Anderson, I totally get what you're saying. I think back to the idea of like wanting to be able to use the formulary a little bit more in the future, that this is going to be a really good first step. And epinephrine is already something that could theoretically be prescribed under one of the protocols that we have, which is continuing therapy, right? So somebody who already has a prescription for something, and as long as you can prove that, you can extend it. So, I mean, I do think pharmacists under the formularies already have that ability to do it. So if they wanted to do it under protocol, I am saying it incorrectly. I'm sorry. There's already a protocol that allows pharmacists to like extend a prescription. And so based on that protocol, pharmacists could already prescribe epinephrine. That being said, so that's, I think, one of the reasons why I think it would be fine to include it on the formulary only for now. I don't think it would really prohibit or restrict pharmacists from getting epinephrine to people.
Yeah, and this is committee member Sellers, and my main thought was really along the same lines as committee member Anderson.
Staff member Melvin.
Melvin. Oh, sorry.
Yes. Okay. I wanted to suggest maybe we're having a little bit of a time problem here. One of our SMEs for PEP and PrEP is only available until 11:30. Would the committee like to discuss or consider the motions after we do PEP and PrEP? We can come back to epinephrine to allow the first set of SMEs to leave the call and to allow Jeff the time he needs to present changes to PEP and PrEP. We want to just come back to the motion so you guys can think about it a little bit more.
This is committee member Sellers. I'm actually ready to vote, but I'm happy to wait if others would like more time.
I'm ready to vote as well, but if we need to move on, we can move on if that's going to take, because voting takes time too.
Yeah.
This is committee member Anderson. I'm good with either as well.
All right. You know what? It doesn't take that long to vote, so we're voting on two separate issues. So let's just get through it, I think would be the best, if that's all right. So the first one is, which page am I on? To move, like, we're voting on the formulary first or the protocol first?
Formulary. So this is going to be mailing A that you reviewed.
Okay. Yep. So mailing A, so this first vote is on formulary, and then the second one is about adding the protocol. So you can vote yes on both or yes on just one of them. All right. So is there a motion to move to recommend adding epinephrine to the devices and supplies formulary to the Oregon Board of Pharmacy for review?
Committee member Virgin. So moved.
I'm sorry, who was the first?
Anderson. I think Virgin, Dr. Virgin.
And then Anderson was second?
Yes.
Okay, thank you.
All right, roll call vote on adding epinephrine to formulary. Committee member Anderson?
Approved.
Committee member Gibler?
Approve.
Committee member Hammond?
Approved.
Committee member Sellers approves. Committee member Virgin?
Approve.
Committee member Wickenhagen?
Approved.
All right, this motion passes. We'll add epinephrine to the formulary. We'll now move on to the proposed epinephrine protocol, which was mailing B, who our SMEs, Sharp and Nutt, already reviewed with us. And so the question is,
Courtney, I'm sorry to interrupt you real quick. For this motion, you will need to say as revised because we made a few changes. So instead of as proposed, we'll say as revised.
Okay.
Thank you.
Is there a motion to move to recommend the anaphylaxis epinephrine protocol version 10, 2025 as revised to the Oregon Board of Pharmacy for review?
So somebody can make a call for a motion and doesn't have to vote in favor of that motion.
Yeah.
So you can still
We're
say
just saying we're just going to recommend one way or the other.
Yeah, so you can still make the motion and vote against the motion.
Wickenhagen submits the motion.
Is there a second?
Committee member Virgin seconds.
All right. And so as the protocol as revised, moving it to the Oregon Board of Pharmacy, we'll do our roll call vote for committee member Anderson.
I do not approve.
Committee member Gibler.
Do not approve.
Committee member Hammond.
Do not approve.
Committee member Sellers votes no. Committee member Virgin.
Votes no.
Committee member Wickenhagen.
Does not approve.
Okay, so this motion fails, but we want to very much thank the SMEs, Sharp and Nut, for all of your dedication and work and your wonderful discussion. We really do appreciate it. So thank you. And we will now continue with review of the proposed protocol for HIV post-exposure prophylaxis, mailing number B1, starting with Executive Director Runyon.
Executive Director Runyon, my part will be short and sweet here. We have a new SME joining us today. I'd like to ask each SME to introduce yourself and prior to reviewing mailing B1.
So Jeff, if you could start us off, and then Sharon, and then Tom Myers, please.
Oh, Jeff, if you're trying to introduce yourself, you're on mute.
Okay, we'll come back to Jeff. How about you, Sharon or Tom?
Hi, I'm Sharon Rask. I'm a pharmacist, and my role at Oregon State University College of Pharmacy is I am the Director of Continuing Professional Education.
Thank you. And Tom Myers?
Good morning. I'm Tom Myers. I'm the outpatient supervisor for Samaritan Outpatient Pharmacy here on Oregon State University campus.
Thank you. Back to you, Jeff. If you can hear us, you unmute. And if Jeff is having technical difficulties, we're going to have to rely on Sharon or Tom to walk us through. Okay.
Okay. He said he is trying to unmute. I apologize. Tom,
Okay,
would you like to start this off, or I'm happy to do so as well. We are requesting revisions to the HIV PEP and PrEP protocols. To start off with the HIV PEP protocol, there were new CDC HIV PEP guidelines released several months ago. And with those new guidelines, the HIV PEP preferred regimens have changed. And so we are looking to, first of all, remove the raltegravir or Icentra, since it's no longer a preferred medication, and then add the new medications that are the preferred protocols. Our other additions would be to really highlight that PEP is really time sensitive and should really be supported, the use within the first 24 hours of use after potential exposure, and add an additional question to the intake form and the inclusion in the treatment pathway if the patient has ever used HIV PrEP, or if they are currently taking that, and for the follow-up recommendations.
Okay, this is Staff Member Melvin. So SME, Sharon, what we're doing is we're reviewing these one page at a time. So for the public's sake, that's okay. On this first page, everything in yellow and in track, well, it's not in track changes here, but anything in yellow highlight and anything that has a strike in it are the proposed changes just on the first page for our cover page. And then I'll move to the second page unless the committee has questions. So please, Chair Sellers, if you could please manage that side of it while we go through these.
Absolutely.
And someone please let me know if Jeff has his hand up, or if I need to come back to the call, please let me know. So if we're ready to move to the next page, I will move forward. I'm good. Intake form.
Oh, committee member Melvin, do you need to unmute Jeff? Does he have a block on from your side?
So unless he left the call and came back,
he might have.
He did, and let me thank you for doing that.
Mm-hmm.
Teams is not a team player. All right, Jeff, how about now? Can you try unmuting? Yeah, it looks like he's probably having the same problem, but I did allow him to come in.
Okay.
Just go back to this window. Okay. So Sharon, we'll have you pick back up.
Okay, thank you.
Yes, so this is our intake form.
On background information on number 2, it looks like the pounds is changed from the abbreviation of LBS would be the first edit. And then down at number 20, this would be the new question added to the protocol. Are you currently taking HIV PrEP? And this could lead to the decision of if the pharmacist would consider that individual a candidate for HIV PEP. If they are taking the HIV PrEP consistently without missing doses, then perhaps the potential exposure may not warrant the prescribing of the HIV PEP. However, if the patient is looking to have that prescribed, the pharmacist could still proceed with that. And it would in fact be challenging many times to truly to verify the med adherence there.
This is Committee Member Gibler. I'm sorry, Smiras, where are we verifying adherence? Is it in the intake form, or are we going to do that elsewhere?
Well, that would be on the pathway, assessment and treatment care pathway.
Okay, perfect. Thank you.
And then looking,
Oh, I'm sorry. So we were done with this. That was the end of the page. So any other committee questions before I close this and move to the next? Chair Sellers. Let's get back to you.
Sorry, is there any committee questions before we close this page and move on to the next one?
And
I don't see
Jeff
any,
is on
so
the
we can move
call
on.
now to
Hello,
provide
Jeff.
more information.
Jeff, are you able to unmute and introduce yourself?
All right, can you hear me now?
Yes, we can.
Okay, perfect. My name is Jeff Leroux. I'm a PharmD working at G Street Integrated Health and a specialist with the American Academy of HIV Medicine.
Welcome.
Thank you.
Thanks, Jeff. Sorry about that. This is Staff Member Melvin. Okay, so we are now back to the assessment and treatment care pathway. Back to you.
Okay, so other updates. We are looking at adding a statement that since post-exposure prophylaxis is time sensitive, the guidelines are including language now that we are starting it ideally within 24 hours of an exposure, but no later than 72. I think this is more of just an update to reflect what is currently being seen in the guidelines.
And Jeff, please stop me. I'm just going to scroll to the bottom. Some of the other things were just small revisions. Okay.
Correct.
Okay, now probably need to speak to this one right here.
Yes. And so this is probably the biggest change. Since we started the protocol, the CDC post-exposure prophylaxis guidelines have been updated. And so raltegravir is no longer preferred part of the HIV PEP regimen. And we are asking that we remove that from the protocol. There have been additions such as Descovy, which is the updated version of tenofovir and emtricitabine. Also, bictegravir, emtricitabine, and tenofovir alafenamide, trade name Biktarvy, is now on guidelines. So we're requesting Descovy and Biktarvy be added to the regimen to reflect the updates.
This is Staff Member Melvin. So did we miss a strike here for this one? or was it just the
So-
Truvada up here?
So actually that's, I think the way that it is laid out there, the intention is, so Truvada is still part of it in combination with dolutegravir. I think that, so Truvada, I think, or I think maybe we could, I'm seeing where, as I'm looking at the form, it should be Truvada or Descovy with Tivicay. Or we could make it Tivicay plus Truvada or Tivicay plus Descovy. I think that might be a more clear way to outline it.
Committee Member Virgin, you have your hand up.
Yes, Committee Member Virgin. My question had to do with the refer to the emergency department. Just knowing that that's always a challenge for patients. And my question was clarification if that is an intent to expedite testing and treatment.
Will you scroll up just a little bit so I can? So, in those situations, the refer to the emergency department is more due to comorbidities that would make that could complicate prescribing of HIV post-exposure prophylaxis. And so tenofovir will treat hepatitis B, and withdrawal of it can cause a disease flare. And so we didn't feel like it was appropriate for a community pharmacist to prescribe in a situation with a patient that has known chronic hepatitis B. Also, tenofovir disproxyl fumarate is associated with a little bit of kidney dysfunction. And so in people that have known chronic kidney disease that may need treatment with TDF, we wanted to make sure that that person had a good baseline assessment of their renal function before we give them something that could be potentially compromising of that.
Thank you so much. And going back down to step 8, I think you were going over those and proposing maybe a different ordering.
So I think where it is, I think as I'm looking at it, there's the 2 bolded ones are the preferred ones. The others, actually, now that I'm looking at it, I think they're looking good. And so yeah, no, that
This
does.
This is Staff Member Melvin. I realize what I did here. In our current protocol that's on our books today, like if you were to open our website, Truvada was listed first. So I put a strike through it. Essentially, you're moving it down here, right? So
yes, and it's
okay.
now
Not
and
new
it's now
language.
yeah, it's now packaged with dolutegravir, which is appropriate. So I think that looks great.
Okay. And these are not duplicates. Okay. So does that does look correct.
Yes.
And then and then the other one we struck was this right here, this one.
Correct.
Okay. So I'm just going to keep going if you are okay with
This
that.
Committee Member Gibler, I have a question. The Tivicay dolutegravir's last 2 options, does there need to be or between the second to the last and the last bullet point, similar to joining all the other bullet points?
Yes, please.
And then let me just below this table, it says or dolutegravir are preferred. So according to PEP guidelines, Biktarvy, Descovy plus raltegravir or dolutegravir are preferred. but I don't, that's conflicting with what we're prescribing. We're not prescribing dolutegravir by itself, are we? We're prescribing it with the tenofovir or emtricitabine. I'm a little, it's just, I guess I'm a little, it feels like it's not aligning with the step 8. I just want to make someone else look at it and just, is this aligning with step 8, what we're writing at the bottom of the protocol here that's highlighted?
I think it aligns, but as I'm reading it, I think just with the regimens and the trade names, it's becoming confusing. And so it says, I like this as a reference. I think that the table above does a better job of outlining what the regimens are. And so if we were going to include the reference to simplify things, according to CDC PEP guidelines, the regimens above are preferred in individuals 13 and older, rather than have a second statement that kind of says the same thing with kind of in a format that's a little, that is right, but kind of just word challenging to read. I don't know how people feel about that.
This is committee member Sellers. I guess, what is the added benefit of having, other than just, I mean, it's our way of sort of shortening that up, and because I do feel like it is confusing.
Yeah, I think that a statement according to CDC PEP guidelines, the regimens are above are preferred for individuals 13 and older does the same thing. We've listed them out there and we're making direct reference to them.
So Jeff, are you suggesting just striking what I have highlighted right now? Like it's not necessary?
And then the highlighted portion immediately after the 13 and older, please. I feel like that's probably a yeah, I like that better.
This is committee member Sellers. I'm not sure it reads quite correctly though. So according to the CDC PEP treatment guidelines, a preferred regimen for
let's modify to, according to CDC PEP guidelines, the regimens listed above are preferred for individuals 13 and older.
All right, I'll clean this up after the fact. Just
Sounds
because
great.
we're on a time crunch, so yeah, so we'll make sure that this looks proper before we send it to our board.
And this is committee member Gibler. Staff member Melvin, if you could just also just add spaces after the doses between the number and the MG, similar to all our other protocols.
Yes, thank you for that.
Thank you.
Okay, Jeff, so I'm just going to continue knowing that you need to leave soon. So we'll just keep going down. If there were any other, yeah, down here. Do we need to modify this now?
I'm looking at the second bullet point on the right. It just is, since we have removed, oh, sorry, third bullet point. That pregnancy is not a contraindication. Our regimens are just a little, I think we need to pull Icentris off there because we're not going to be using it. And update that to include Biktarvy and Descovy.
Sorry, I do not know how to spell that. Okay.
Okay.
And everything on the left, though, is proper. This looks correct to you.
Yes, yes, it does.
Okay. Right. And counseling points, we removed that.
That is great counseling points for Biktarvy. Also agree with PEP to PrEP.
Okay, and that's new language, and then striking that follow-up bullet. Okay. So Chair Sellers, back to you for committee discussion before we close this one.
All right. Does anybody have any further questions on the treatment pathway for PEP? All right. I think we're on to the next.
So patient intake form, back to you, Jeff.
Okay, so once again, updating to include Biktarvy and Descovy while removing Icentris. Okay. And then including language that patient should consult the pharmacist if they feel like they are still at risk of HIV infection. So considering risk factor reductions, PEP to PrEP if appropriate.
All right, and that's the end of that. Back to you,
All right.
Chair Sellers.
Any questions from the committee? Okay, on to the next document.
So once again, adding Biktarvy, language with Tivicay and Descovy, some just verbal or grammar corrections for the changes. The baseline testing has not, recommendations have not changed, and so we're not making any additions or subtractions there.
Staff Member Melvin, I'm going to just interject really quickly. There is a new federal digital accessibility law that's going to come into play, and the state, we are working feverishly to amend documents. So I've removed anything that had red text on it has been changed to black or highlighted in yellow. Okay, back to you, Jeff.
Okay, so the prescription form has been updated to reflect the new regimens that are available.
Courtney, back to you, and I'll pull up the.
Yep. Any questions on this committee?
This is committee member Wicken again. I was just concerned if we didn't have some sort of language that said for pharmacy reference only, not for public distribution.
I'm sorry, Sarah, are you talking about what's in the footer right now?
Not the footer, but just the prescription itself. I guess I'm just a little nervous about making sure that it's clear that this is only for pharmacy use. But maybe the footer alone is enough, but just trying to be careful. Thanks.
Okay, this is the one we amended. Okay, Jeff, I think that's everything for PEP. Is that correct before we move on to PrEP?
That looks great.
Okay.
All right, and we'll move on to PrEP unless any committee members have any additional questions for Jeff before he has to leave. Okay, take it away.
All right, good morning. Yeah, I'll just go through the proposed changes for PrEP, starting with the first page. Looks like we're crossing that out, changing the numbering on that page. I think that's it for the first page.
Minor, yeah. Take form.
Just change some of the language there because we're proposing adding injectable as well as having oral. So we just change it to HIV there. Yeah, switching to HIV. Including the dosing regimens for cabotegravir and lenacapavir. Oh, I think that's spelled incorrectly.
Oh, yes, it is.
Yeah, and just saying if the base labs aren't resulted by the time of initiation for PrEP, we can't do the injectable, so we'll do a 30-day supply of the oral while we're waiting for the labs to result.
All right, Committee Chair Sellers, back to you because this is the end of this page. If there's any
All right.
questions?
Anybody have any? Does anybody have any questions? All right, back to you, Thomas.
Thank you. Change the language for this. We have algorithms for the oral and an algorithm for the injectable, and so we just change the language for algorithm A to reflect the oral PrEP initiation. We changed the language here because we didn't want that to be a barrier to access to care. That is still listed as a baseline test, but there's also language. Oh, sorry, someone's hand came up.
This is Committee Member Gibler. I think we still have LBS instead of pounds in this document. So if you want to change that.
Thank you. Good eye, Andrew. I'll scour all of these documents before we send these to the board, I promise. Okay, Tom, back to you.
Thank you. So that's why that's being modified. Next, we added a lipid panel for the Descovy just because studies have shown that there's a marked increase in cholesterol levels with this medication. So with reviewing the literature and looking at Virginia's protocol, this is also something that they list for their pharmacists to do. So that's why I wanted to add it to this as well. This is algorithm B for continuation of oral PrEP with the addition of the lipid panel. And we just switch the language here.
I'm going too fast. Just could someone let me know, please. Didn't change that table. This one.
This is for Appendix A, which we changed to say oral for the oral. And the addition of the lipid panel. Again with oral.
A lipid panel.
Yep.
Doesn't know. What's a lipid panel? Oh, I'm sorry, can you tell me what a lipid panel is?
Oh, they're measuring the cholesterol levels, like the total cholesterol, LDL, triglycerides, just because they've shown that by starting to Descovy, it can significantly increase these.
So you're saying that the pharmacist can order the lipid panel?
Correct. Yeah.
So I don't think you can.
Nope.
That's in statute that you can know all that's. Well, let me look at.
Jeff, is this something that you do at your practice, or?
So yes, and I work in an ambulatory clinic, and so for all patients that I initiate PrEP, especially if they are on TAF, emtricitabine, I'm ordering a lipid panel at baseline. It's recommended in the guidelines.
Okay, staff member relevant. So Tom, I think while we have legal and executive director running looking into that, let's continue and then we can come back to this.
Thank you. And this is a new algorithm. This is for the algorithm for injectable PrEP initiation. Follows the same language as the Virginia Board of Pharmacy protocol as well.
Committee members, please tell me if you would like me to stop in any particular area of this. It's all new.
No, this is committee member Gibler. Just you're going to go through these, but just you got some more LBSs. So.
Oh yeah, I'm going to search every one of these.
You're gonna.
Okay.
This is committee member Wickenhagen. I do have a question about the ability of a pharmacist to administer the injectable PrEP. I was under the impression that it had to be administered in the setting that requires a provider. So just if that could get looked into legally as well, that would be great. Thanks.
I'm sorry. Sarah, we're having a hard time hearing you. It's really echoey. We could not hear your question in our room. Can any other committee members?
Okay, trying again. Can you hear me?
Yeah, it's just
this committee member Gibler, what she's asking is that she isn't sure that cabotegravir can be administered outside the presence of another provider. I think is what she said. Injectable.
Sarah, go ahead. Try again.
Yeah, that's exactly right. I just had a concern about the ability to offer this in the injectable form and the requirements around that. So if somebody could look into that legally, I think that would be great, because I'm not sure. I had a different interpretation about this, that it had to be provider administered.
Committee member Anderson, Sarah, are you referring to this drug specifically, or just whether or not pharmacists can administer drugs?
Just to PrEP specifically, I thought there were some special considerations in regards to the injectable PrEP options versus the oral. And I may be mistaken, but I just was hoping someone else could potentially look into that.
I'm looking at the statute.
Real quick. So I think definitely clearing it up legally. I can speak to in practice. Of course, like I said, I work in an ambulatory setting, so the rules are a little different. In terms of the actual ability to inject, I think pharmacists definitely qualified, are trained to do this. And then there are also opportunities through the manufacturer for trainings and things like that if the pharmacists want them. And so if it is a legal issue, whether or not it's statutory allowed, I totally understand that. But I think in terms of actual clinical ability, 100% support pharmacists doing this. I do administer it personally in our clinic too.
But I mean, what the statute says, I don't know if there's a different rule on it or not, and I can try and look at that, but the statute just says a pharmacist may prescribe, dispense, and administer pre-exposure prophylactic antiviral therapies. So that would mean any, right? I mean,
Which the, what's it?
so 689704 2A. So that
Thanks
would
for
be like, there,
yeah,
I mean,
thanks for
there might
keeping
be,
that out.
I can look in the rules to see if anything went further to try and like, I'll double check, but you guys can keep going. I'll let you know if I see something different.
Okay, Tom, we'll just continue where we left off. Are we right
Addition
here?
of the, yeah. No, we added a Appendix C for the injectable prep as well. And we added the oral prep if the baseline labs hadn't been resulted yet. They can start oral for 30 days while we're waiting for those labs to be completed. And algorithm D is for continuation of injectable prep. Same changes as before. And then Appendix C was the same for both initiation and continuation. So I just combined them into one Appendix C, and they can be referenced there. And here's the table for the required laboratories and the scheduling for those.
And we're now at the end of that document. Okay, back to you, Committee Chair Sellers.
All right, this is Committee Member Sellers. Does anybody have any questions? I know that was a whirlwind, but wow, you guys did a lot of work on these. So kudos to you all. That's amazing. Did we get the question about labs answered as well?
I think we need I think we probably need to take a break.
Okay.
You come back to that. Okay.
I mean, I order labs on patients every day. So
Yeah, this committee member
hopefully we
Gibler, I
can
mean,
do
we
it.
got serum creatinine and everything that needs to be ordered, so I'm not sure why a lipid panel would be any different.
Yeah.
Committee Chair Sellers, yeah, we are overdue for a break. We were just really trying to accommodate Jeff. We just weren't sure how long epinephrine was going to go. So I think now would be a good time to take a break, or if the committee wants to discuss taking a lunch break. We weren't sure how long this was going to go today. You all?
Can I propose just maybe a 10-minute break, and then we can come back and because we have these.
It just depends on how long. This is Committee Member Gibler. If we still have a ways to go, then I would like a lunch break. But if we're going to wrap up when we get back, then I'm fine with 10 minutes.
We take 15 minutes just so I can do the thing and then also go to the bathroom.
Yes, and then Committee Member Gibler, we have the provider facts to continue for prep, the prescription template, and then a motion for that, and then And then you all need to look at the standard vaccination protocols and the rule. Yeah, we have, and then COVID and influenza protocols have some minor changes, and then chikungunya. Yeah, we have a little bit ways to go.
Yeah, I need a lunch. Sorry.
Okay.
And I
So
got to catch
Courtney,
up on.
would we like to take lunch now then, or take a break and then come back and then go to lunch from 12 to 12:30?
This committee member, Anderson, how much longer do we need to get through this particular protocol? Or are we needing to wait for people to look into things?
There's that as well.
Okay, if we have to wait for those things, I propose we come back to it and take a lunch now.
All right, shall we close and resume at 12:10? Give about half an hour.
Sure.
That works.
Okay, we'll reconvene at 12:10. Jeff, thank you for your help. Sorry we weren't able to finish with you, but take care, and we appreciate all of your hard work. And we'll see the rest of you at 12:10. Thank you.
Thank you, everyone.